And hello, everyone. Welcome to our webinar for Clinicom, the clinical value of Clinicom. Thanks, everybody, for joining us. We will be taking questions for Dr. Handal as the presentation has concluded. We have just a short introduction here, and then we'll get started. Okay. Thank you for joining us, everyone. Welcome to this highly anticipated webinar, The Clinical Value of Clinicom. We're on the cusp of a new era in mental health care where technology and compassion converge to create transformative patient experiences. Today, we'll explore the innovations that are not just shaping the future, but are actually defining it. It is with immense pleasure and honor that I introduce our distinguished speaker for today, Dr. Nelson Handal, MD, DFAPA, a visionary in the realm of mental health technology. Dr. Handal's contribution to the field are both profound and pioneering. As the founder of Clinicom, he has consistently pushed the boundaries of what's possible, merging clinical experience with technological innovation. His dedication to enhancing patient care and clinician experiences has set new standards in the industry. Dr. Handal's journey is not just about technological advances. It's a testament to his unwavering commitment to improving mental health outcomes for patients worldwide. His accolades and recognitions, including being acknowledged by Forbes and the APA, are a mere glimpse of his impactful career. Without further ado, please join me in welcoming Dr. Nelson Handal as he takes us on a transformative journey into the world of Clinicom and the future of mental health care.
Thank you, Marcus. I appreciate that introduction. The value of Clinicom is not only a technological value. I think we have stressed that many times. But I wanted to focus on the clinical value of Clinicom. Why? Because it's very important to understand the impact that Clinicom has on the patients, on the clinicians, and on the community. So let me focus on some of the disclosures first. We have been doing many studies over the past 15, 20 years. And I wanted to make sure that everybody understands what companies we work for. And basically, from the very beginning, we started funding Clinicom based on the work that we did in research. Next. So Harmonix Neuroscience Research has been the company that has developed Clinicom over the years, and the funding came from the sponsors that we have done research for, over 200 plus trials. And then it's important to understand that later on we moved Clinicom to an independent company. But Harmonix really was the pioneer here. Those of me here in Medicine Clinic, I'm the founder and chairman also of this clinic. And this clinic serves 3 states. Half of our patients come from more than 2 hours away. We see about 250 to 275 patients daily. We have therapists, nurse practitioners, 4 board-certified psychiatrists. And then I'll obviously disclose that I'm the founder and chairman of Clinicom Healthcare. What we will try to do now is I'll really briefly show you how Clinicom was developed in a clinical setting. We will talk a little bit about the validation study that we published in 2018. I will show you the domains we always talk about the biopsychosocial model of psychiatric care or mental health care. I will show you some of the domains that we have on Clinicom for that. Um, I'll show an example of how these algorithms look like, the clinical algorithms, um, and then the clinical and research value of Clinicon, and then we will talk about three case presentations and interpretations. So the three cases will be the most important part of this presentation. I'll go a little fast over the other slides. So in 2004, I had the idea of doing something where the patients could complete something online, an assessment online. It evolved quickly into a lot of challenges. This is not easy to do. So we beta tested it like 10 years later. And we had something that was working out okay with some developers from Germany. Next. We had to add more conditions as we had to upgrade our encryption, had to be HIPAA compliant, and then later on, obviously, more challenges came as we had to develop alerts, develop graphs, and um, be open to custom assessments. The important thing here is one assessment can identify up to 80 plus conditions, which that never happens, but most patients have two or three or four conditions or five, etc. um, then we thought, okay, we need to have some follow-up for these patients who are completing the assessment. So we developed that some years ago, and then we translated it into 4 different languages, and then we added it to the Apple Store. Um, so in 2018, we published our validation study, which it was self-funded. It was difficult to do, but we published it, and we'll talk very little about it. You can always look at it online. Um, we added more questionnaires. So as the DSM starts making progress, we have to catch up with it, and every time is a little difficult to catch up. But we got that, and now have to. We started commercializing Clinicom in 2020. We have very, very good staff, including Les Jordan, who was CTO for Microsoft Life Sciences. Okay, I'll end with this in terms of the development, but we updated the Clinicom to the DSM-5 TR. Um, you know, we added 25 conditions there, and now Clinicom really is being used in many, many sites in the US and in some other areas of the world. Next. So the biopsychosocial model that everybody understands the importance of it. The domains we have in Clinicom for this for the assessments, you can read there. There are many domains, including development of as a child, conception, pregnancy. Some people may omit these details, but they are extremely important, and we will see why. You have primary complaints, secondary complaints. Next. Oh, one thing that I didn't want to forget to mention is that every condition, when is suggested for diagnosis, comes with a very clear narrative with the name of the patient. Other domains that every Clinicom assessment has is adoption, and I'll show you why that is important. Military history. We see a lot of vets in our clinic, and it comes extremely handy to understand why we have to get more history of their military exposure. And we will see a PTSD case later. Family history to me is extremely important. And so we go up to the third generation assessing family history. Safety, patients have been abused, neglected, or anything like that. So it's important. The support system is very, very important. I saw a patient today who has absolutely no support system. And then if you don't know that, you cannot validate the severity of the case appropriately. Obviously, education, legal issues, stressors. We have 99 stressors from what I remember, so the patients can just click on whatever stressor they're going through. Um, Legal issues, quality of life. Next. All right, this is just an example of how complex these algorithms are. This is the algorithm for measure depression, and you can see this is extremely complicated. So you see the algorithm, but the algorithms are built on something that we develop ourselves. After failing many times to use algorithm builders from other developers, we developed our own algorithm builder on which we develop our different algorithms that are extremely complex. Next. So our validation study from 2018 showed basically that Clinicom is specific and reproducible. It's a reliable online tool, and we use our own proprietary algorithms to determine the patient's type of condition, the severity of the condition. It's important to understand the severity of a condition, because a condition could be mild and present or could be severe or extreme. Um, so this study was very important for us, and we have plans to complete other studies next. So you can see the concordance there. We tried to match some of the 5 most frequent conditions that we see, and there was significant concordance for these 5 conditions. Next. And then the retest reliability of the conditions was also very important, and so it's a pretty reliable test. Next. Okay, so in general, I mean, this is a list of the clinical values for patients, but I want to highlight a few. Many patients may not be very clear about their symptoms sometimes, unless there is a concrete set of questions that ask about a set of symptoms. So this is very, very, very important to me. Um, you know, the other important thing is the patients can elaborate about their own condition, because there are boxes where they can type whatever they want. This was very questionable at the beginning, back 10, 15 years ago, but now is very accepted, and patients elaborate much more on these boxes, or in front of the computer, than they elaborate in front of a psychiatrist or therapist many times. And then you have to think about, this is happening one time. The patients are sitting one time doing the assessment, but then they can stop and come back later if they want to, or 2 days later, and they will find their assessment exactly where they left the last time. It took a while for us to be able to do that. Again, think about this. This has been created in a clinical setting with researchers, clinicians, and real patients, and then has been tested over and over and over again. So we found that it is extremely important for the patients to be able to, take a break and come back and things like that. The important thing here also is that the patients can be evaluated themselves. They can evaluate themselves, or they can get an assessment for a child, if it's a parent or a guardian, for an adolescent. When it's an adolescent, we let the patient's guardian and the adolescent do a clinicum themselves. It's a very safe and secure place to share sensitive information. Um, so the patients can ask their doctor for to share a PDF, and then bring the PDF somewhere else for further interpretation. What I love to do with my patients is I have a monitor where I usually use a tablet, and then I put the Clinicom results and I scroll through my tablet, and then the patients can see the assessment on a monitor. I think that is extremely valuable because you can explain the patients what is going on, what symptoms do they have, why they don't have certain conditions. They may come saying, "Hey, I have bipolar disorder," and they may not meet criteria for it. So teaching them, it will improve their uh, rapport with you, but not only the rapport, but the outcome. It, because they will know exactly what they're looking for, especially when they do the follow-up assessments. Next. Okay, so this is the value for the clinician. So you don't have to spend several sessions because you really know, then you know what's going on with the patient. So you maximize the time, and then the value of the whole biopsychosocial assessment is incredibly important, as everybody knows. So you can reduce the time for stabilizing the patient, and that in turn will uh, make the patients very satisfied, as we will see later, and then maybe refer other patients to you. Um, and then how you make decisions about what to treat first. Let's say a patient comes with depression, and the depression is mild or moderate, but they have also ADHD, and the ADHD is very severe or extreme. Are you going to treat the depression first, like most experts say, or are you going to treat the ADHD? You know, so things like that are very, very important. We will uncover hidden comorbidities. Some patients may not know that they have OCD or severe social phobia, or may intuitively know, kind of, but you will uncover it. So that is important. On the follow-up, if you have follow-ups, you can see how your meds are working, and then look at the outcomes of your care. All right, next. I don't know if any of you do research, but I just have a list here of the importance for research. I will just focus on a few things. So you can triage patients. Every research patient, we triage them with Clinicom first, so that we can invest more time on that patient before doing other scales, or the scales that the sponsor wants, and say, hey, no, this patient does not is not going to meet criteria. This patient or this subject has exclusion criteria, for instance. So we triage all our patients with Clinicom to do our studies. Next. Okay, so in general, the utility of Clinicom is based on doing one assessment for the patients, to do one assessment that can evoke several conditions, and a biopsychosocial. I'm sorry, in the biopsychosocial part of it. Um, we also have standardized scales that are that we were allowed to offer. So, for instance, you can use the MADRS and send the patient a MADRS for whatever reason you want to add that, or any scale that we have permission to use. You will be able to see what scales we can offer. Important is to understand that once you saw the patient, you can on Clinicom you can accept, reject, rule out, or add any uh, diagnosis that you think the patient meets criteria for and that you want to treat. Um, you can the follow-ups, for instance, you can set the follow-up automatically to be every 3 weeks, every 6 weeks, every 6 months, whatever you want. I love to use that because you can set up your assessment follow-ups based on the outcomes that you're expecting. Um, you can do you can see graph statistics. Is pretty complete. Go ahead, next one. Okay, so you can use any platform. Next. So here is just an example of the narrative that you can get with the diagnosis that's on the right side of the screen, how you can accept or reject the diagnosis. Next. And these are the follow-ups. You can see it on the left side, several follow-ups assessments there. Next. And here's you can add whatever diagnosis that is your priority. You can add that diagnosis and you can put the severity of it. So this survey was done with I think over 1,000 users of Clinicom, and the results that we have are the following. 92% said it was easy. Actually, Clinicom is developed, and we have had uh, specialists revise the way the questions are asked at the 8th grade level. So it's very easy to use, also easy to understand. It was thorough, and most patients completed it under an hour. Um, you can see how much time the patients took into finishing Clinicom. Okay, now I'll try to let's see. We will see first a PTSD patient. Uh, Marcus, can you see this?
Yes, we can, Dr. Handel.
Okay, thank you. Okay, so these cases that I'll show you are de-identified. In other words, we took the names and other important information that pertains to the patient. We took that all out. So if you have a patient that comes in and you want to look at their Clinicom before you see them, there is an assessment result. It's like a summary, which is this page here that I'm showing. And this patient uh, completed the assessment. He's a 42-year-old male. And already you can see that this patient is going to be difficult. You can look at the assessments a day before so that you can organize your time better. So, but you can see here clearly this patient has a suicide warning. The severity of every condition goes from 1 to 7, like a CGI. And so we have to be worried with this patient. Has suicide warning, is meeting criteria for PTSD, is irritable, maybe has some symptoms associated with some thought disturbance, aggression. Okay, so I chose this case because I thought, okay, um, we have to show the value of Clinicom in a patient that is complex, not in a case that is simple. Okay, so what I will do here is I will view the report, and the report starts here. So this patient, it took time for him to finish all these questions. He completed 482 questions. Not everybody will have 482 questions. It depends on the answers that they give. So intuitively, Clinicom will ask more questions if needed. Um, so you can see here in color, you can see the severity of the conditions. Um, so for instance, the patient scored 15 out of 27 on the PHQ-9. Everybody's familiar with the personal health questionnaire that people use to assess depression. Now, I have to tell you, we have had sometimes patients who didn't score high or scored under 10 on the PHQ-9, but we had seen that the patients, when they have to answer the questions based on the algorithms I show you about major depression, they met criteria for depression. Um, the generalized anxiety disorder 7, he's on 13 out of 21. This is for drugs, that does 10, and audit is for alcohol. So already you can see that we have a patient that's not going to be so easy to assess. He meets criteria for ADHD, but it's mild. The ADHD is mild, and some social anxiety, panic, it's mild also. But I'm going to go here. He has marked PTSD. So you can click this arrow to go to the symptoms. And let me see if I can. Okay. So the patient experience, you can think about the patient experiencing, witnessing, or learning of. So this is what the DSM suggests you consider in terms of evoking PTSD or a traumatic event. So this patient experienced, witnessed, and learned of some traumatic event. We know that he was or is a vet, but it's kind of surprising to see that he has been traumatized even um, uh, earlier in his life. He was sexually and physically abused by his father. So when you see a vet, I'm not sure they will tell you this stuff, and how important it is to know that they have been abused in this way. So you have to understand that this is incredibly valuable. Um, Also, the patient was, as you can see here, harassed, and bullied. He was placed in a mental health ward. That in itself is very traumatizing. Um, and then experienced the violence in the military. He has seen other people get hurt or killed. Um, these are set answers, so the patients click on the answer that they think they should concentrate on. So he's let me see. Here he's describing that he received a mental, sexual, and physical abuse by his father, and then the father did the same thing to his mother. And then he says experienced wartime events during 4 deployments to Iraq. So if you want to address issues associated with veterans and military exposure, and then the patient comes in and they tell you they're a vet, they have been exposed to traumatic events in the military. If you see that isolated from the problems that this particular patient had as having traumatic experiences as a child as well, then you will not be able to help this patient completely, because these other traumatic experiences may uh, have a as big or a greater burden on the patient's symptoms that you can see here are very severe. All these are ADHD. I'm sorry, PTSD symptoms. They're very severe. Um, but the other interesting thing to me here is that when the patient describes uh, his traumatic experience uh, here and here, it's not very elaborate. It's short. I have seen patients who really describe this, and there is no limit to the amount of words that they can put in there. But I think this patient may be defensive, trying to disclose what happened, but not giving you too many details. So it's important to have this and then ask the patient, okay, tell me a little bit more about the details of your traumatic experience as a child, or what traumatic experiences can you describe about having in Iraq? Okay. So, in addition, this patient obviously has marked generalized anxiety. Um, and you can see here depression as well. It's moderate. But you can see here also that the patient had thoughts about harming himself, thinking about dying. Okay. So, thinking about dying uh, on itself may not be very worrisome. But if you think about a patient with this level of traumatic um, experiences, then you have to take this very seriously. He's saying uh, he never has done this, but the last time he thought about dying was 7 days ago. And, he thinks about dying very often. And then you can see here the reasons he wants to die, and these are set answers. So he has to click on the ones that he identifies with. So there are two things here that put the level of risk for suicide very highly. One is hopelessness, and the other one is loneliness. Those are the two most predictive symptoms of suicide. Nobody can predict exactly, but if somebody is hopeless and lonely, or at least even if they are with other people, they feel lonely. Obviously, if they have depression, uh, pain, shame, you have to take this guy seriously. And he thought, okay, what if I'm gonna have to carry this for the rest of my life? These painful emotions and physical pain. He's 42 years old. Um, he says he has no plan, and has some difficulty controlling his thoughts. All right, moving on. He doesn't have bipolar disorder, but he's obsessive. He's obsessive. Um, I have always thought that patients who have OCD may have more trouble dealing with their obsessive compulsive disorder. I'm sorry, with their post traumatic stress disorder, because they're ruminating, about the issues, and they cannot control their thoughts, so they obsess about the trauma sometimes. So would you know that this patient had obsessive compulsive disorder? Probably not. If you have 1 hour and sometimes half hour to talk to a patient, they come in, they are depressed and anxious, and they get some antidepressant. That's not the appropriate way to treat these patients. And this is the mission that I really seriously think about. We have to get as much information as possible, but we don't have the time. Um, there are some negative symptoms that this patient is experiencing, as you can read there. Anyway, I'm going to move on. Sleep problems. He's irritable, as we said today. This is an independent algorithm that we have for irritability, and it's 6 out of 7. So he's a very irritable person. Okay, so we are going into the medical part, the treatment history. He has had therapy, he has had counseling. See, read what he's putting on the text box here. Talk therapy or most therapy to me is talking about what we need to fix, then talk about talking. So many issues, hard to pick a focal point. It's what we were talking about before. There's so much that this poor man is going through. Um, so you know this may be important or not, but this guy had some speech impediments but he got better with therapy. He's not adopted, so uh, his psychiatric history, uh, he has not been hospitalized, uh, but probably was about to be. He has these problems, these medical problems. It's important to know. I mean, if you have all these problems along with the traumatic experiences and the symptoms that you have, life may not be fun at all. By the way, Clinicom has an algorithm for traumatic brain injury, and I'll try. This is the military history he has, and you can see the dates. He was in the army. Some of the details here. The unit commander. I mean, he's describing him as having lack of compassion and competence. That is important to know. Even for therapy, it's important to know. Okay, so here his 4 deployments in different years. Okay, so I need to go a little faster here. um, you can see the family history, the violence. I mean, you get the idea of how important it is to have Clinicom. How can you see patients without all this information and be successful? I don't know. Okay, I'm just going to move on. Here are his stressors, his education history, employment. Okay. All right. We'll move to the next patient. I thought we said a bipolar patient. I don't remember exactly, but we'll try bipolar patient. This is a 40-year-old female, and you can see she met criteria for mania, 6 out of 7, and then it was and with depression, and so she has 6 out of 7 severity of bipolar disorder. I wanted to bring this case up for the reason of how important it is to understand that bipolar disorder is very difficult to diagnose, especially if patients are younger. But let me see. You're familiar with all this, but I want to emphasize here the mania. Okay, let me. Okay, you can see this patient has severe mania. And the only challenge we have with Clinicom in diagnosing mania is because some patients don't remember how long their manic episodes have been unless they are so severe. Because if they are 4 days, 5 or 6 days, it could be bipolar 2. And if it's 7 or more, or if they have been hospitalized with mania or suicide risk, obviously they may meet criteria for bipolar type 1. But this patient, um, so what I want to emphasize is the more severe the symptoms, the more likely they will remember their episodes of mania. And the duration of it is very important, because if they put here 1, that doesn't meet criteria for mania. So then you talk to the patient and say, hey, you remember these episodes where you had these symptoms? And many times that helps to change the duration. Let's see. This patient, the other good thing about this patient's story, and let me go back here. Um, you can see in the summary, the patient is getting better. You can see that's the other extremely important thing about Clinicom. As if you can do follow-ups on the patient, you can see the patients getting better. Also, you can see graphs of how the patients are getting better. Okay, I'll go into details about this last patient that we will talk about. Okay, this kid is 6 years old, okay? And I saw him actually last week, and I thought it would be interesting to present this case. You can see the patient's mom completed the report, um, presents with ADHD, with OCD, aggressive behavior, oppositional defiant disorder, irritability. The GAD7 is kind of high. Um, well, borderline, as well as the algorithm for Clinicom, he's 3 out of 7. Every case will have a GAD7 in PHQ-9, because that's a requirement for insurance to get reimbursed for Clinicom. But you can get reimbursed for it. I'm not going to go into that, but definitely you can. Okay, so let's look at the report. Okay, so this child is coming in with already some guanfacine for, I guess, treatment of his hyperactivity or impulsivity. Okay, he has ADHD, ODD, and conduct disorder is borderline, anxiety, obsessiveness, irritability, and aggression. So, well, let's see the ADHD first. Okay, you can see he needs 6 out of these 9 symptoms. He has 7 symptoms positive. Any symptom that is yellow or red or orange is positive. He has 9 out of 9 of the symptoms of hyperactivity. These last 3 symptoms are impulsivity. So he has combined ADHD, combined because it's attention and hyperactivity impulsivity. The severity is 5 out of 7. So we know already this guy has ADHD. He has oppositional defiant disorder, moderate severity. Well, what does this mean? I'm not a big fan of diagnosing kids with ODD, because many times, or by the DSM-5, you can't diagnose somebody with ODD if they have any mood disorder. Um, but this is interesting. He has borderline conduct disorder because he has been lying, shoplifting. Remember, he's 6 years old. Destroying property, threatening. Okay, so remember, this kid is adopted. Okay, so the first thing when I see some symptoms of conduct disorder, I want to see the family history, which we will see in a moment. Uh, he does not meet criteria for PTSD because obviously it's very hard for 6-year-olds to report intrusive memories or other PTSD symptoms. But the adoptive mother here is saying uh, that the kid was with his biological parents until age 11 of his life, and that time was volatile, numerous police reports, domestic violence exposure. Um, During the time that the mother was pregnant with him, she also abused drugs, so there is prenatal exposure to drugs. Okay, how important is to know this? uh, I cannot emphasize the importance of it. If this kid would go, let's say, for a referral to a doctor and say, hey, the guardian will say, well, he's hyper, he's impulsive, he's aggressive. Okay, let me give him guanfacine. Okay, that's what happened actually. But this kid has more problems than that. Um, okay, I'm gonna move a little faster. He's obsessive also. Okay, I want to go to more the psychosocial part. He doesn't have autism. Okay, so a few times a week, he's irritable, uh, 5 out of 10 in severity. So he gets better when he talks or he's talked to or listening to music, etc. This kid had a very good mom. And I told her this kid would be 10 times worse if he didn't have the support that this mom had. Okay, there you go. With a conceptual pregnancy, we have problems already, all kinds of problems with prenatal exposure. We know nowadays that exposure to violence in pregnant women can cause severe disruption in the baby's development. And then you have this: the mother was unresponsive, when giving birth at some point, C-section. Delayed motor milestones, and then he caught up later, thanks to these parents that who adopted him. Anyway, I don't want to extend myself too much, and we need time for questions. But one thing uh, I wanted to ask the adoptive mom. Okay, why did you put that there was no legal histories? Are you sure there was no legal history on the family? And she corrected it and said, no, 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 there were. Both parents had been in jail several times and breaking the law, and for disputes that they had, and marital disputes that they had at home, etc. So if I see anybody with conduct disorder, I look straight here, and most times you will see that the young patients or adult patients may have history of legal problems. So he has very good support now. Um, there is another kid who lives in the house and another foster son. which is good because that way the kid is being cared for not only by the parents but by the social structure. Okay. Anyway, I'm gonna leave it there, and I guess we can go back to questions.
Yes, Dr. Handel. Thank you so much for the presentation and for going over those particular case studies. So I'm going to paste in just a couple of uh, questions that were submitted to me prior. And we'll go to, let's take this off and we'll go there. One of the questions is, given the rise of telehealth, how does Clinicom complement virtual consultations?
Obviously, during the pandemic, we used telehealth. Like I said, we see many patients a day, and all the clinicians and doctors used telehealth. So it's using Clinicom and telehealth, to me personally, is like you know, using two pivotal uh, um, tools to complete a good assessment when you cannot see patients in person. We have been seeing patients in person in this past year or two that we had never seen before, and we were treating them for 2 years. It's a different experience, but they complement each other. Actually, there are one or two very large telehealth companies that are very interested in using Clinicom at the present time.
Okay. We have another question. Do you chart into the Clinicom?
Yes, you can add notes to Clinicom. You can chart into Clinicom. You cannot change what the patient reported. I hope you understand why. You don't want to change any of that. So that you cannot change, but you can add notes. You can actually, for instance, also if you use EHR, you can copy and paste very simply some of the narratives that you find interested into your EHR.
Okay. And Lisa actually has a follow up question, which is um, let's see, once Clinicom is completed and you meet with the patient, how do you rule in and rule out the diagnoses?
You have to talk to the patient. Like I said, we sit down with the patient, we show them on a screen their answers, and go case by case. And then once you are sure, after talking to the patients, that um, confirming the severity of their symptoms and the duration of their symptoms and the social consequences of having symptoms like that in their functioning, you can accept the diagnosis. Clinicom has a space where you can accept, like I said, accept, reject, rule out. Maybe you need some symptoms later, um, the diagnosis, or add any diagnosis that was not evoked.
Very
It's
good.
very,
And
really very easy to do.
all right. And Lisa says she does that and she loves Clinicom. So thank you, Lisa. We appreciate you.
You're welcome.
Okay. And the next question I got was, how does Clinicom facilitate collaboration between different specialists or departments within a healthcare setting?
Okay. That is a really good question because Clinicom assesses medical problems. As, for instance, a patient may have seizures, may have TBI, traumatic brain injury. The patient may have had, for instance, I saw this morning a patient who had uh, irritable bowel syndrome. And then, so once, if we have Clinicom and the patients are disclosing these medical problems that mm, even their primary care doctor may not know, for instance, like this PTSD patient had migraines, you know, uh, and he didn't have care for that. So having Clinicom, I'll tell you a better story very quickly. So I don't know if most people are familiar with conversion disorder, which is neurological symptoms due to some psychological problem. So if a neurologist in town referred me this patient who had uh, severe neurological symptoms that he thought may need to be evaluated for uh, um, having conversion disorder. So the bottom line is this lady would make very funny movements with her hair, with her head, that she thought were seizures. She had weakness in one of her legs, in one of her arms. And Clinicom helped me understand that this patient had gone through extreme trauma when she was little, from age 8 until 17. At age 17, the dad died, and the dad would physically abuse her every single day, um, with the belt buckle. And so I told her, well, maybe at some point you couldn't cry anymore. Or she said that the dad would get angrier if she would cry. So I said, so you had to put this face of like crying, but you were not crying so that he wouldn't get worse, more upset. She said, you know what? Totally. I said, so why did this start about 6 months ago? She didn't have that before. The long story is, it's a long story, but the short version of it is that she, one of her daughters, moved with a guy to Florida. She lived in Alabama, and they had a child who was 6 years old. And then I asked this lady, I said, do you think that maybe uh, you're extremely worried about your grandson suffering the same things you suffered? And she started, I mean, it was very dramatic. She started crying and said, yes, the same thing could happen. And I didn't put two and two together, and she started making the movements that she was making. The bottom line is, I told the neurologist that she definitely has conversion disorder. But if we didn't have Clinicom, we would not know exactly where it's coming from.
All right, very good. I think that's the conclusion of the questions that I have. And with that, I think we'll conclude the webinar. I want to thank everybody that participated and gave their time and attendance today. And thank you, Dr. Handel, for
Thank you.
everything that you do with your practice and with Clinicom. And with that, we'll say goodnight.
Thank you.